Good evening, everybody. Officially welcome to August's Conversations with Caregivers. And tonight our guest is Paul Rea, who will be introduced in a few moments. I just wanted to go over some Zoom logistics. And it seems funny that I have to look at my paper since I do Zoom all day, every day. But I want to make sure I don't miss anything. So everybody, all the participants are muted. Please don't accidentally unmute yourself, just so, again, we can keep it as quiet as possible to focus on our featured speaker. There is the option to view this in a speaker view, which is you focus on the speaker. There's gallery view where you can kind of see everybody and say, oh, who's here in the room with me? We will be using the spotlight feature tonight, so I'll be pressing a button that says spotlight when different people are talking, but you can always skip it on speaker view or move to gallery view. Down at the bottom of your of your machine, to the left of the share screen button, please don't hit that, is the chat box. So that's how we ask questions. So if you, as Paul and Susan are speaking, if something comes to mind and you're like, oh, I want to know more about that, feel free to put it in the chat box even as we are talking. Susan will be kind of keeping an eye on that and curating it. So you can use that during the presentation or at the end when we open it up to Q&A. You might see that it says this is being recorded. So please don't share any personal information, any medical information, your social security number. Just keep that to yourselves. And so we do record this, and then it's hosted on the MGH Geriatric Medicine website, which I usually, when I send out an email announcing the next event, I give that link so you know where to find it. I think those are all the Zoom logistics. If you want to stop video for any reason, you can press the button that says stop video down in the lower left.
Can I add something? I'm going to interrupt.
Yes.
Just on that note, if you feel comfortable having your camera on while you're muted, it's really helpful to those of us who are speaking to be able to see people and make sure we're engaging people and we're making sense. So if you feel comfortable, we'd love to see you.
Yeah, good to have that community. Thanks, Susan. So I'm going to turn it over to Susan. So Susan Rowlett, she is the program director for the Dementia Care Collaborative, and she is a clinical social worker with the geriatric psychiatry team here at MGH. Susan received her master's degree in social work from Boston College, and she is licensed as an independent clinical social worker. Susan spent the early part of her career providing clinical care and developing programs for those living with chronic and serious psychiatric illnesses and their families who were all impacted by the illnesses as well. Susan believes she found her calling in 2005 when she was given the opportunity to participate in launching a family counseling program at the Alzheimer's Association under the guidance and leadership of Dr. Paul Rea, tonight's speaker. Tonight's presentation will focus on methods developed by Dr. Rea, which directly influence the work that we are continuing here at MGH today. And on that note, I will turn it over to Susan.
Thank you, Nori. Hello, everyone. It's so good to see familiar faces and familiar names. So welcome tonight. I'm going to speak quickly, but I wanted to take the opportunity tonight to make sure people who are active in our programs that you know a little bit about the Dementia Care Collaborative. So I may say a little bit more than people usually say. I'm going to talk really quickly because I don't want to take any more of Dr. Rea's time than we need to. But I just wanted to, and I haven't been actually moderating these talks, but they're letting me out in public tonight. So I'm going to take the opportunity to talk a little bit about the work that we're doing here to make sure you know. So the Caregiver Support Program launched 3 years ago. It was actually October 2017, so almost just 3 years ago, under the leadership of our division chief, Dr. Vicki Jackson, and our primary benefactor and the heart and soul of our program, Dr. Roman DeSanctis. He's the director emeritus of clinical cardiology at MGH and devoted caregiver to his wife through her journey with Alzheimer's disease. When I met Dr. Jackson for the first time, the vision she described to me was nothing short of the transformation of the healthcare system to be dementia friendly. And she didn't use those words exactly, and I wasn't sure what she meant, but I knew that I had to be a part of it. We started doing numerous needs assessments, talking to doctors and clinicians throughout the hospital to find out what's missing, what do we need to do, how can we be helpful to make sure MGH is providing the best possible care for folks with dementia and their families. And there was a lot that we learned. So about that same time, Barbara Moskowitz, who is here with us tonight, and I set out to learn and build relationships at MGH and start reaching patients and caregivers where many receive diagnosis and treatment for dementia at MGH, and that's in geriatric psychiatry and the memory disorder unit in neurology. Without much of a plan, honestly, Barbara and I started providing counseling for patients and caregivers in those departments, and that was the beginning of the caregiver support program. So over time, this thing we were creating began to grow. This year, we launched our memory care program in primary care. We have several initiatives in the emergency department. So if any of you have ever experienced the emergency room, we're really working at MGH to make things better there. I also want to say that we are also creating leadership teams to create hospital-wide plans to implement the Massachusetts dementia care legislation and age-friendly hospital standards set out by the Hartford Foundation. So you can imagine all of this work requires a lot of collaborative effort. So to more accurately reflect our work, about a year and a half ago, our program was renamed and rebranded the Dementia Care Collaborative, striving to break down barriers of communication to become a centralized location for information support and coordination of dementia care at MGH. With all of our growth, I want to point out that the Dementia Care Collaborative's foundation is the work of our caregiver support program, providing critical social work and social work services and geriatric assessment for patients and families seen in specific clinics within MGH. Beyond meeting with those individual patients and families, we provide what we like to call a menu of options to anyone who is interested, whether you receive care at MGH or not. Conversations with Caregivers is an example of one of those programs that's available to anyone everywhere. We are developing a health and resiliency program, which many of you attend classes with Nori Mazzone for Ageless Grace. And we have 2 new programs coming up in September that are going to focus specifically on health and resiliency for us all. And I want to put faces to the names of our team members that many of you know, especially during this time of COVID when we wish we were meeting you all in person. But I think it's actually great that we're all, maybe even more people are able to be here tonight since we're together virtually. So I'm going to start. Nori Mazzone, say hello to everyone. Nori is our program coordinator and our Ageless Grace teacher.
Hello, everyone.
It's our senior project manager, Judy Willett. Judy is the brain behind it all. Hello, Judy. And I'm reading here. I got to make sure I don't miss anybody. Chris White, wave hello, Chris, is our social worker in the neurology memory disorder unit. Did I miss Barbara? Barbara Moskowitz, our Associate Director of Education and Support. Her clinical work is also in the memory disorder unit in neurology. I saw Gabrielle Rex. Gabrielle, are you here? Say hello.
Yeah, thank you.
Gabrielle is our nurse practitioner, and she works in the memory care program at the Bullfinch Medical Group in Newton Wellesley Hospital primary care practice, along with Kelsey Anderson, our social worker in the memory care program. I don't know if Kelsey is here with us tonight. Our medical director, Christine Ritchie, is not here tonight, but you'll be able to meet her in October when she will be one of our keynote speakers. With all of this being said, many of you may not realize the Caregiver Support Program is entirely funded through philanthropic support. If you're interested in learning more about our programs or how you can support the work we're doing, please reach out to one of us directly or reply to Nori, who emailed the invite for tonight's program. We genuinely love to hear from you, and I mean that. Also, if you feel you've benefited from our programs, you may know others who can also benefit. So please spread the word for us and help us as we continue to grow this amazing community. So thank you for listening to my story, for indulging me and talking about this program that I'm so proud of. And we're so happy to have you all here together tonight. So now I'm going to introduce my mentor and my friend, Paul Rea. I'm just honored, Paul, to have you here tonight. Dr. Rea has worked in the field of gerontology and psychology for 40 years, For 30 of those years, he did pioneering work while serving as Vice President for Professional Clinical Services at the Alzheimer's Association, Massachusetts, New Hampshire chapter. He's currently a consultant to residential care facilities, expert advisor to state and federal healthcare agencies, and a mentor to professionals from around the world. Dr. Ray has been recognized and has received a multitude of awards for his distinguished service. Most importantly, I think of the thousands of individuals and families who've been directly or indirectly impacted by Dr. Ray's wisdom and compassion. Tonight, Dr. Ray will give us a window into habilitation therapy, the evidence-based comprehensive approach to dementia care that he developed in the early years of his career, which is now a part of our care curriculum here at MGH. He brings to his work a unique sensibility, wisdom, compassion, and humor. This is a great opportunity to learn from Dr. Ray, so please type your questions in the chat box. We want to hear from you. We'll spend about half of this evening's program having a conversation and answering your questions. We'll do our best to respond to everyone. So now I'm going to stop talking and I'm going to turn it over to Dr. Paul Rea. Thank you, Paul.
Thank you, Susan. You read it just like I wrote it. It's a pleasure to be here with you and to share some of the things that I've been working on for the last few years. To begin with, I think it's important to just talk about some numbers. And there are over 6 million individuals who have Alzheimer's disease. And I want to stress that that's a guesstimate. We really don't know the actual numbers because most people with Alzheimer's never get really diagnosed one way or the other. They may, if in the best of circumstances, carry a diagnosis of dementia, but it isn't specified. But many, many, many poor people who never get to see a neurologist or psychiatrist or anyone never really get diagnosed one way or the other. It's really thought of as benign aging in terms of the symptoms that are recognized. So we don't really know the numbers. We know that they're large and that there are many more people caring for those people who actually have Alzheimer's and related disorders. And some time ago, some students that I was working with, we did a study and we found that for female caregivers who gave more than 3 years of care to their loved one with the disease, it could be a husband or a dad, they actually suffered from post-traumatic stress syndrome disorder in every diagnostic category. And it took a couple of years for those symptoms to diminish. Others have found that, again, those caregivers, and the sample in this case was female, who gave more than 3 years of care in the home, actually increased their chances of getting Alzheimer's because of the stress and depression that they experienced over the course of giving care. And so it's a disease that not only affects the person who is being cared for, but we can also say that the caregiver and the extended family are also suffering from symptoms associated with the disease. Many years ago, I started a group for young children who had grandparents with the disease, and they had symptoms of stress and depression. So it's a disease that affects the entire family at various levels, and the caregiver, the primary caregiver, is in a situation where they need the skills to help them better care for the person and help them to emotionally get through the experience. And I was involved in developing a technique called habilitation therapy, and which I will explain, some years ago. And I realized that it was a very different approach to care. How we define something determines to a large extent what in fact we will see. For example, before Galileo, the ancient astronomers assumed that humankind was at the center of the universe and that the sun and all the celestial bodies revolved around Earth. And that's the way they saw the universe, by that definition. And if we choose to see Alzheimer's and define it differently, a whole new starscape opens up to us, a new way of seeing the disease and a new way of our giving care and working with the person who has the disease in a better psychological environment. So I would say that we have to choose to see a whole new starscape, and that starscape starts with seeing Alzheimer's as not just a life-threatening disease, which it is. And ultimately, in most cases, the person is going to die of Alzheimer's disease or something related to it. But rather, we see Alzheimer's as a period of time in life where the person still has the ability to appreciate life through positive emotions. And that's the crux of it, that if we choose to see Alzheimer's in a way that is more like a disability rather than just a deadly trajectory, but a disability, then we can put in place things that help the person cope better with their disability. And in a sense, it's now putting the sun, the earth revolving around the sun rather than the sun revolving around the earth. So that's where we start with habilitation. It's habilitation, not rehabilitation. We're not seeking to restore the person to the way they were. We can't do that. But habilitation means that what we are trying to do is enable the person to use all their resources at any point in the course of the disease to have a better appreciation of life and have a better relationship with those around them. And we're choosing to see Alzheimer's as a disability, as I said, and trying to bring the person to the point where they can actualize all the remaining capacities at any point in the course of the disease, early stage, middle stage, and later stage. Unfortunately, we haven't really seen others looking at Alzheimer's in this way. There are other competing definitions of Alzheimer's, or competing ways of looking at it. You know, one way has been, and I think it's probably the most dominant one, is that Alzheimer's is not really a disease. It's not seen as that. It's seen as an inevitable part of aging. And as such, that, you know, we don't do anything special. It's just normal age-related changes. Another definition of Alzheimer's disease and related disorders is that it requires palliative care. In other words, we're taking care of the person the best we can as they are in the process of dying. And as such, the people who are providing this care, both family care providers and professional care providers, are not given the skill sets that that would enable them to get to that part of the person that is still there and utilize those remaining skills in the best possible way. Another definition of dementia is that it's incurable at this point in time. It's a disease that has one direction and it's going in, and that we can't really change that trajectory. So we have to put all our resources into finding the magic pill that will make the disease go away. And so that we're not putting resources into what I would call the psychology of Alzheimer's disease. And that's what habilitation therapy is. It's a psychological approach that looks at emotions, the ability to feel an emotion, the ability to express an emotion, and the ability to hold on to emotion as being the primary area in which we can concentrate, and by using a set of skills, enable the person to maximize their cognitive potential, because they're not having such an emotional reaction to their loss of abilities, nor is the person who's giving care to the person focusing in on what has been lost, but trying to appreciate what is still there. So this is a psychology of dementia care, rather than a more medically oriented approach. So we divide habilitation into domains. And a domain is simply an area in which you have the ability to bring about a positive emotion. And the reason we focus on positive emotion, if we look at what happens in the brain with Alzheimer's disease, the last part of the brain to really be affected by neurofibrillary plaques and tangles, the cornerstone of the disease, is that part of the brain very deep called the amygdala. And the amygdala is the part of the brain that appreciates and works with very basic emotions. The more sophisticated emotions located in the front of the brain and in the sides of the brain are affected fairly early in the course of the disease, and so that we don't have access to them in the same way that we did before. So habilitation is focusing in on those emotions that are processed, the basic emotions that are processed in the amygdala. And domains are an area in which we have an opportunity to affect those emotions. So the first domain that we want to talk about is the physical domain. And the physical domain is basically saying that there are a number of cognitive things that happen that cause the person not to be able to utilize their physical environment, the things that are around them. And we know, for example, that the person's sense of smell changes very early. We know that the person's sense of vision changes very early. We know that the ability of the person to track an image moving across their visual field changes very early in the course of the disease. The person has difficulty seeing certain colors by mid-disease. And cognitively, they can't often figure out what the physical cues are actually still telling them. And so it's as caregivers and as practitioners, our objective is to make the physical environment stand out in one way or another. Let me give you an example. If, because of memory loss, if you put a jar of peanut butter in the cupboard, that person with Alzheimer's may not have access to that peanut butter because it isn't in visual view. But if you put the peanut butter on the counter, they're better able to recognize the label and recognize what it's used for and be able to use it. So it's looking at how the person is able to physically respond to the environment around them. One of the things we know or the best thing that we can do overall, is to recognize that light plays a very important role in being able to see in the first place, but also almost more importantly, is light affects emotion. And so the typical home is lit at about 40-foot candle power. And I would recommend that, particularly in the winter months, that we increase the candle power to at least 80-foot candle power. So just put more lights around at a higher wattage so that the person isn't seeing shadows. We want to make sure that the person isn't coming into a room and facing a window from across the room, so that that light source is obliterating their ability to see the detail in that room as they're walking into that room. So positioning of light is extremely important. The intensity of light is extremely important. And we know that we can, particularly in the wintertime, change what used to be called sundowning, because it really had more to do with the absence of light, by just increasing the amount of light in the room so the person doesn't see a transition from light to dark that's outside. We'll talk a little bit more about light in more detail later, but the physical environment also has to do with color. And we recognize that the person doesn't, in the mid-stage disease, doesn't see all of the colors. They only see the primary colors. And that we can use color coding to help the person function more adeptly by using color coding to signal the steps in any cognitive task. I'll talk more about that later. Noise is another issue that the person is in the physical environment is affected by. Older people in general, myself included, might have a hearing loss, which makes things sound different, or they're not picking up all the cues in the environment. So hearing aids may be in order, but certainly speaking more loudly is important, or not having loud, scary noises to disrupt the person in the course of the day. The physical environment is an important thing to look at, something that we can control. But I think what is more significant to this discussion is looking at the skills of communication that caregivers use. And there are what we call, this is yet another domain of habilitation, and we divide it into the rules of communication, and then secondly, the approaches to communication. The rules are very straightforward and simple. You always approach the person from the front. You always make eye contact. You always say their name and your name. Now, I know if you're in a family situation, that may sound awkward, but you can always just say, "Hi, honey, it's your loving wife, Amy." So that you're orienting the person right off in the very beginning. They don't have to think, who is this? Do I know this person? They know who I am. You're using their name. You approach them from the front, but as you approach them, you want to make sure that you're making eye contact. And there's some really interesting data about eye contact in folks with dementia. As they make eye contact with you, it's very important for them, because they're looking at the dilation in your eyes. Subconsciously, they're processing this information. And it's an instinctual kind of thing. And what we see is that by mid-stage disease, as the person with dementia's eyes are dilating in synchrony with the person that they're speaking with. We see this in young children, and we see it in animals as well. But it's something that it's a reflex that comes back with middle stage dementia. And what I would also suggest that you approach the person from the front, make eye contact, but you sit to their left-hand side, causing them to turn their head to the left, therefore activating the right side of the brain, which has more capacity to deal with processing emotions. So that may be helpful. You may touch the person and take their hand, particularly if it's a family caregiver. If it's a professional caregiver, you want to probably ask permission of that first. But that may be helpful contact to make, just to have a physical connection to the person, and then give instruction or converse in any way possible. Make sure that the person is hearing you. That's essential. Those are some of the rules of communication. But I think more important are the strategies of communication. And the first strategy is that we never want to make known what the person has lost. We don't want to verbally say, oh my gosh, you made this mistake. And that is only going to cause a negative emotion. And the whole focus of habilitation therapy is to bring about a positive emotion and to maintain that, and to help keep that positive emotion over the course of the day. To bring about a positive emotion and keep that positive emotion active over the course of the day. So you don't want to say to the person, oh my gosh, look what you have done. Oh, I told you how to do that. Don't do that. Those are the kinds of things we just want to make sure we get out of our behavioral bag of tricks. Let me illustrate that with a true story. A woman was taking care of her mother, and she was going to take her mom, who had Alzheimer's, to a restaurant. And she shows up, and mom's all dressed with her handbag and her coat on. They go off to the restaurant. They're shown to their table, and mom takes off her coat, and she forgot to put her dress on. She's there in her slip. And the daughter's immediate reaction would have been, oh my gosh, mom, look, you forgot to put your dress on. And what would mom have, would have mom reacted to that? With shame and embarrassment. And that would have obliterated any chance whatsoever that they could have a wonderful meal together. So the daughter thought for a moment, and she said, oh my gosh, mom, it's chilly in here. I'm going to put my coat on. You must be cold too. You can put your coat on. And once that happened, they were then able to go on and have a wonderful meal together. But if she said what she initially was thinking, oh my gosh, look what this disease has brought you to, there would have been no chance whatsoever to then continue that meal. Another related issue might be, and again, this comes to mind with a true life story. We had a patient in a nursing home who was infatuated with Arthur Fiedler, the older conductor of the Boston Symphony Orchestra years ago. And this person was admitted into the nursing home, and for the first few days, she really wasn't eating very well. So this nurse who had heard me give this kind of lecture about rehabilitation therapy goes down to the kitchen and brings up a tray, and she says to the lady, "You never guess who came in this afternoon. He heard you were here. It was Arthur Fiedler. And he saw me bringing up this tray, and he told me to tell you you should eat this." And she did. And every meal thereafter, Arthur Fiedler said she should eat it. And I know some of you are thinking, well, those are, you're asking me to lie to my loved one? But in fact, these are not lies. These are what we call therapeutic fiblets, little fibs that enable you to help the person get through the embarrassment of an error they have made, or an embarrassment of a symptom that they didn't expect to be there. A fiblet is helping the person overcome a dysfunction and bringing about a positive emotion instead of a negative emotion. Another related strategy of communication is we never, ever, ever use the word no. If the person wakes up at 4 in the morning and they decide they want to go roller skating in the middle of a snowstorm, the caregiver should say, "What a great idea. I don't know why I didn't think of it myself. Let's do it." The minute you say the word no, what happens? You set up a negative emotion, and the person's muscles tense up, their eyes dilate, their voice changes, and their whole emotion changes. You're trying to obstruct what I want to do, and that isn't going to happen. So let's avoid that. Never use the word no. In this case scenario, maybe the person could say, "It's a wonderful idea, let's go outside, but before we go, let's have a cup of coffee and a sandwich." And you're going to use two related skills, refocusing and redirecting. You refocus the person's attention to something different, and you redirect their behavior to something different. So you could say in this scenario, we're going to go outside at 3 in the morning, but before we go, let's have a cup of coffee and a sandwich. My favorite kind of sandwich is peanut butter and jelly. What's yours? So the person has to think for a moment. That's redirection. And, excuse me, I just confused it. That's refocusing the person's attention. That's refocusing. And let's go make that sandwich. That's redirection. They're going, you're starting to make the sandwich. That's going to take time. And that time is going to erode, hopefully, the person's original intention that I want to go out. So refocusing and redirection. Another skill, communication skill, is that we want to make sure that we are helping the person express what they need to say to us, but restrict the emotionality around what they need to say. For example, someone with Alzheimer's might say, "You took my pocketbook. You took it, and I want it back right now." So one response might be, I didn't take it. Well, that's just going to set up a confrontation. Yes, you did. The person isn't going to be able to admit that because of their faulty memory, they lost it. It's much easier to say you took it and to believe that's true rather than accept your disease. So the person is then going to have an argument with you, and that's going to bring about a positive emotion that's going to, a negative emotion that is going to linger for the number of hours after this whole confrontation. So we want to avoid that at all costs. So what might you say if the person says, "You took my pocketbook"? One response might be, "Oh, that's awful. Let me go help you find it. Let's go look for it together." And then as you're looking for it, you can refocus and redirect. Again, using time to erode the person's original memory. I don't know where my pocketbook is. And you're going to refocus and redirect with positive cues to bring about a positive emotion. Another way you can respond is not only to offer help, but to say something like, you know, when I lose my pocketbook, it makes me crazy. I know exactly how you feel. Let's go look for it together. So you're acknowledging the person's underlying emotion at that time, and you're offering help, which may be necessary in certain cases, to acknowledge that basic emotion. I know how you feel. Yes, I would feel the same way. You're empathizing with that person. Another domain of habilitation is the functional domain. And in this domain, we want to eliminate all the barriers to the person acting in a way that is using all the remaining skills that they have. The person may not be able to still cook, but they may be able to cook with you, and if you give them certain tasks that they still can do. And that's going to bring about a positive emotion because they're contributing. And you're asking them, well, how do I do this? And how do I do that? But you're still giving them a task. The functional domain is also making sure that the things that they need to do a particular task are there. Let me give you another example. Oftentimes people with Alzheimer's disease have difficulty dressing themselves. And I actually visited a man and whose wife had Alzheimer's and who had that same complaint. He said, my wife can't dress herself. I have to do it all the time. And I said, well, how do you get her dressed? And he said, Angelina, get dressed. And then she would go upstairs and he'd come back 10 minutes later and check on her, and she'd be standing in front of the closet. She couldn't make a choice. And I said, well, what you need to do is get all those clothes out of the closet. She was confounded by all those choices that she had to make. Put 2 or 3 items in the closet. And then come up and say, well, we have this wonderful blue outfit. We have this wonderful red outfit. I favor the blue one because it matches your eyes. Which one would you like to wear today? And once the selection was made based on Angelina's stage in the disease, she could then dress herself. But the husband was saying, Angelina cannot dress herself. What she couldn't do was make the selection from an array of items to choose from. And so that's what the functional domain is all about. It's enabling the person to use whatever skills they have in order to function at whatever level they are at any stage in the course of the disease, which brings about a sense of fulfillment in the person. Not that they can't do the task, but they, with assistance, can do some part of the task. And that's extremely important, to enable the person to do that. Another domain is in understanding behavior. And behavior is a very complex area, and it takes some understanding of the antecedents to the behavior. Let me give you an example of a behavior that occurred in a nursing home. And this man was in a nursing home, and when he was seated in a certain area, he would just simply get up and hit another resident. And then he didn't show any emotion, but he would just hit that resident and walk out of the room. So I said to the staff, I said, you know, we got to figure out what's at the base of this. So I said, let's keep a behavioral log. And a behavioral log is where we just write down what happened, where it happened, and when it happened. And then we periodically look at that data and say, well, maybe this is what caused that behavior. We can rule things in and out as to the cause of why that person was doing what they were doing. In time, what we found was the person who was doing the hitting was in this particular room, seated on one side of that room, where the light was coming through the window in his eyes. And he would just get up and hit the person who was seated by that window. And it was always a different person. He never hit the same person twice. But the knee-jerk reaction, because this was in a nursing home, or it could have been if it was even in your home, that we would have given the person antipsychotic medication to change that behavior. And we all know that antipsychotic medication, if it's not controlled correctly, can really have a lot of side effects. But by analyzing or using tracing of the behavior, we were able to see that the behavior was caused because the light was in the man's eyes. And all we had to do was make sure we closed the blinds during the day in that room. And that we did, in fact, do that, and the behavior went away. So what I want you to think about is, what are the antecedents to the behavior? And to try to do some mapping of that behavior to see what the basic cause is, and then how can you eliminate that cause in the behavior. Oftentimes, it's something that the caregiver has done. I may have responded too harshly. My tone of voice may have not been correct. I didn't enable the person to do the task at the level that they were able to do it. Let me give you another example. Man in a nursing home is having great difficulty with showering. He would hit the person. He couldn't initiate showering himself. The nurse would say, take a shower. He couldn't do that himself. What we then did was take him down to the shower, but he was still hitting the aide. What he was concerned about was he didn't want to have the aide see him naked. So we showered him in his bathrobe with a handheld shower nozzle. And we started from the feet up. And one thing I would tell you, by and large, almost every person I've ever dealt with who had forms of dementia have trouble getting their face wet in a shower. So we would use a handheld shower nozzle and start from the feet up and stop at the neck. And then wash the hair at a separate time, perhaps, or enable the person to wash their hair themselves and use the handheld shower nozzle only from behind the person so they don't get water in the face, which causes them to panic. In this case, we did behavioral mapping, and we saw that the individual, the man in this scenario, didn't want to have the person see him naked, and he didn't want water in his face. Once we stopped that, he was perfectly fine with showering.
So Paul,
let me just stop here.
Well, I wanted to just say, because you've gone through the 4 domains, and it's just always so remarkable to me that how this philosophy of care can be applied to so many specific situations throughout the course of the disease, early stage, mid stage, and late stage. So we've just been getting such wonderful questions that I wanted to give you an opportunity to respond to people's specific questions, because what I learned from you for so many years is that anything really that comes up, you kind of use this thought process to evaluate what the problem is, and then start to brainstorm on what an answer for that specific family, caregiver, and person might be. So I would love for us to practice that a little bit with some of the questions that have come in. Is that okay?
Mm-hmm.
Okay, great. An early stage or at least pre-diagnosis question. There's really 2 from the same person. Would habilitation benefit an elderly person that may not have dementia but is aging? And then she went on to say that her 95-year-old grandmother is struggling with the lack of routine, memory loss, and is experiencing negative emotions with family members, which is very hard on the family who's caring for her. Is there a better way to handle things to focus on bringing forth positive emotions, such as habilitation? And how do you know, this is the big question, how do you know when to have a loved one evaluated, and how do you approach that delicate conversation?
Let me take the latter part first. I suggest to families that they form a small group of 2 or 3 or 4 members of the family, or it could be of friends, just to make sure that you're all seeing the same symptoms or same things that are there. Because sometimes family members will see things and they're not really validated. You want to get 2 or 3 other people to come to some kind of consensus that we're all seeing the same kinds of symptoms that are worrisome. Once that is established, then I would go to the person with the disease and say, we have seen, not just me, but the group has seen a number of things that we're concerned about. Now, we want you to understand that these things could be caused by something that is very treatable, and that we need to see a doctor just to get it clarified. I don't want to immediately say, you know, we're concerned that this could be dementia. Could be something that's very treatable. And then I would get the person's consent to go to the primary care doctor. Before that person gets to the primary care doctor, I would say that a member of the family should either call the primary care doctor and tell them, or him or her, about what they're seeing, or write a letter or email and indicate what the family has been seeing, so that the primary care doctor has some idea of why the person is making this visit and what the issues are. I would also say that a family member should probably accompany the person in question to that visit with the primary care doctor. But it is, if the person who you're concerned about realizes that it's not just the spouse or the adult child that is seeing this, but other people too, and that it's probably treatable, they're much more likely to get to the primary care doctor.
And Paul, I would just add to that I think for us to know that so many things that are treatable, whether that's maybe medication side effects and interaction of different medications, or a vitamin deficiency, or an infection of some kind, or what, those kinds of things that need to be, you know, evaluated first. That's the first thing you do. If those things are cleared up and there still is some lingering memory problems or symptoms, it's still important to clear those things up, because if they're not, it's just going to make it harder for the person to think clearly.
Right. If there are medical issues, you know, you've got to treat those medical issues that might be the underlying cause of the cognitive problems. But if I think if that doesn't work, then I think the next step is that we probably want to get a neuropsych evaluation, or a neurological evaluation, and at the same time a neuropsych evaluation. And oftentimes a primary care doc can, you know, rule out or rule in certain things that are of concern. But in time, if you've given those things a chance and nothing clears up, then the primary care doc or the family needs to say, I think we need to go further with either a neurological evaluation or a neuropsych evaluation, or both.
Yeah. So Paul, would you say this particular person was asking about their 95-year-old grandmother? So would you say you know, is there a difference, say, if you're in your 60s and you've had, you know, it's interfering with your daily life versus someone who may be, it might be very difficult for them to go through neuropsych testing. How do you kind of balance that? How do you balance the
Yeah,
need for diagnosis
right,
versus the
right.
harm to the person?
I think that with a 95-year-old person, you know, it's fairly easy to be ageistic
Yes.
and say,
Yeah. Yeah.
you know, well, she's 95. What do you expect?
Right. Right.
But I think it's important to break out of that mold and say, well, you know, maybe we do have to do a neurological evaluation.
Mm-hmm.
And just make sure we're, you know, what it is we're dealing with here. I think my prejudice is not to just say, well, she's 95,
Right.
and what do you expect, but to try to get to, you know, the source of the problem, one way or the other, so that the family has something to rally around.
Yeah.
So that the family can say, I need to change the way I behave.
Yeah.
And that is in coordination with the cognitive decline that I will expect to see.
Right. It does help people kind of separate the symptoms from personality, right? So that,
Yeah,
you know, this person
yeah,
is just being
right.
stubborn. They're, you
That's
know,
right. He's just doing this to irritate me.
right.
And to realize that, you know, the person has a condition that is causing them to do this.
Yeah.
And so that it enables the caregiver to show more empathy and to learn some of the skills that we were talking about.
Right. I'd also just reflect on it for that same person that, you know, you're here tonight, you know, you're concerned about your grandmother, you're clearly seeing symptoms that have brought you to a conversation like this. And that's really what is so important for everyone is to learn, to be educated, to find support about these kinds of things and not just ignore it. Because I think we do, like just exactly what Paul is saying, this is very serious, and it's very confusing for everyone. It affects the whole family. So we deserve to know what's going on here, and certainly starting with the primary care physician to make sure there are no, you know, medication interactions that are causing the problems, and et cetera. Other things that can be treated, and possibly maybe get a further neurological workup to see if there's a degenerative progressive disease going on.
Another issue is driving and safety here
Right,
too.
right.
And so that we want to make sure that we have enough medical evidence to say to the person, you should not be driving.
Yeah, exactly. And, you know, that goes along with the first part of her question, which was, you know, she's seeing all of these symptoms. Will habilitation strategies and techniques be helpful, even without a diagnosis?
They absolutely will.
I agree. Do you want to talk a little bit more about that? Just about how, you know, the thinking about how we approach someone differently when they're experiencing these kinds of problems. Why we'll be more successful with the habilitative approach.
Well, our natural tendency is to interact with the person the way we always have. We assume normalcy. And it's very hard as a caregiver to get out of that format. And once we as caregivers can accept that there's an issue there that we need to change in order to have a meaningful relationship with that person. How many times do I see spouses, particularly male caregivers, who have difficulty adapting to some of the principles of habilitation, but once they do, they say, our relationship has significantly improved. And I now can feel love for her, and I can also see that she loves me. We're not constantly angry with each other because I've changed my approach and saw the disease from her perspective.
Yeah.
And in terms of lowering the stress level for caregivers, and in fact now lessening their risk factor for getting dementia themselves, it's so important to adapt to some of these skills, or adopt these skills and adapt to a changed relationship that is still loving.
Yeah.
The person can still express love, the person can still feel love, and that's where we want to be.
Yeah. And, and this person just responded that, thanking you for your feedback and how much she wants to cherish this time with her grandmother, and how important it is for this time to be, happy for her. And so I think so often we're pushing people to get better. We're pushing them to do things that maybe they're not able to do anymore, and then sometimes it leads to tension and conflict, and there is a stepping back and saying, how is there a different way I can approach this, because clearly something's going on, and if person is unable to change because of whatever's going on, it is the caregiver's responsibility, and burden, I would say, but we have to adjust our behavior and our approach. Would you say that's true, Paul?
Yeah, one of the things that have inspired me over the years was a quote I read some years ago by a noted psychologist, A.L. Loria, who said, humankind does not exist by memory alone. They're made up of free will, moral being, but most importantly, the ability to feel, give love. And I think that's what habilitation is all about. That we learn to communicate with the person at a different level that enables us to freely give love and to accept love. And keep in mind that the person with dementia is clearly able to respond to love and to still feel love. And we have to find ways to tap into that. And that's what makes the experience worthwhile of being a caregiver, where you can still have that level of love. And I think in this case with the 95-year-old woman, that they're certainly able to, we don't have a diagnosis here, but communicate, learning the skills that enable you to give love and receive love. That's what it's all about.
Yeah. And I always say to people, Paul, I know everything I know I learned from you, so I feel like I'm just kind of saying what Paul has taught me before. But that, it's the human response to maybe get frustrated or irritated with our loved one, the people that we're closest to. We have a normal relation, our relationship for so many years has been a certain way, and this requires us to stop and reflect that I may have to change how I'm communicating with this person.
Yeah.
And it's so hard, but
We haven't accepted how the
way.
person has changed.
Right. So
And
it's the human reaction versus the most compassionate and humane reaction. Yeah.
Right.
Yeah. So many good questions. Okay. So there are some, then there's some advanced disease kinds of questions. The person I'm caring for was diagnosed with vascular dementia, has difficulty walking, challenges from getting up from the couch. I think that may speak to some apathy and lack of motivation, but also the functional impacts of dementia that start to happen. So I wonder if you want to speak a little bit to, well, I just want to add that, sort of tie this in with another question here from someone who's caring for someone who requires total care with everything: ambulation, toileting, transfers, eating, dressing, and not speaking very much. So, those later stage issues and how you apply habilitation to those situations.
Well, in the later stages of the disease, that the first thing I would say is that you got to recognize that you may need some help giving care. Because if you're doing that 24 hours a day, that level of care, it's going to influence your emotions, and you're not going to be able to use habilitation fully because you're going to be so upset yourself and tired yourself. So I would first say in middle and later stages of the disease, recognize that you may need physical help with giving care that enables you to replenish your soul so that what you bring to the person with the disease is someone who is emotionally capable of interacting in a positive way with the person who has the disease. So recognize that you need help, and it's going to benefit you. You need to have time away if at all possible. Secondly, I think that habilitation enables you to find the issues that the person can no longer do, and find what they still can do and allow them to do it, which in turn gives the person with the disease a sense of accomplishment and improves their emotional status. That's the trick here, to not do too much for the person and find what they're still able to do and allow them to do it. And that brings about a positive emotion because they're contributing to their care. At some level, the person with the disease is very guilt-ridden by what they're putting the caregiver through. They realize that. And they feel saddened by and guilty by having their disease impact the caregiver, the family caregiver.
Yeah.
So it's enabling the person to do as much as possible for themselves that will enable you, the caregiver, to do better, but also the person with the disease to do better.
Yeah. And I think what comes to my mind too, Paul, is there are two things. One is just communication, positive communication from the beginning all the way through the course of the disease is really the foundation to me. So that if you're needing to help someone with those personal care kinds of things, thinking that there might be embarrassment or shame or, like you said, guilt around it, that, you know, it is hard, but we practice the habilitation approach to come to it with a positive emotion. So one thing that you always taught me, Paul, is maybe not to ask, do you want to take a shower? Do you want to change your clothes right now? But, I really need your help with something in the bathroom. Can you come help me with this? Or just starting out one step at a time.
Right.
And just,
there's a very basic skill set, which, if you remember, I called it spend 5 to save 20.
That's right. Yep.
So you come in and you sit with the person for 5 minutes before you initiate any personal care task. And you just chit chat. You talk about the weather, you talk about vacation, you talk about some experience that brings about a positive emotion in the person with the disease. And then you simply say, come with me.
Yeah.
You don't say, would you like to take a shower? Or it's time to take a shower.
And certainly don't start with that.
We don't start with that.
Right.
But you've spent 5 minutes to hopefully reduce the 20 minutes of resistance to the task. You've gotten the person in a positive emotion by talking about the grandchildren or talking about the dog, whatever, vacations that you've shared, and then you initiate the task. And then as you initiate the task, you can use cueing, where you say to the person, okay, if they're going to brush their teeth, pick up the toothbrush, pick up the toothpaste, and you cue each step as the person is doing it, so that the person feels like they're doing it themselves, but you're giving them the verbal cue. With showering, as we talked about before, or bathing, we talked about toileting. Oh, actually, we didn't talk about toileting. Let me give you,
That's a big one.
yeah. There are all kinds of problems with toileting. In one case, it might be that the person has lost the sensation that they need to go to the bathroom. And that could be a physiological thing, and that needs to be checked out first. But more commonly, what we see is the person maybe forgets where the bathroom is,
Right.
or they get to the bathroom and they can't undo their clothing easily. Let me give you an example. I had a case where a man was not urinating in the bathroom easily. I instructed the caregiver to find a red toilet seat. And as I said earlier, the red, yellow, and blue are the primary colors that remain in the visual spectrum. So the red toilet seat, as he walked into the bathroom, drew his attention, and that's where he went. I also suggested that she get little pieces of red paper and put it in the toilet so it would give him a target to shoot for.
Yeah.
And that worked for a long time.
Right.
It's not that the person is always incontinent. It's a cognitive thing about finding the right place to go, being able to manipulate the clothing in time. Sometimes it's recognizing the sensation that you have to go. So it's focusing in on the cues that the person requires in order to them to be continent.
Right. So we're really talking about all the domains. Here's just sort of a question to address other than Alzheimer's disease. So this person asks, will rehabilitation work with FTD where the emotional states are damaged? You know, I'll wait for your thoughts on that, Paul.
It should. You know,
I've so.
to be honest with you, I've not had experience with that, but it really should. You're connecting emotionally with the person, and that should steady the relationship that the caregiver has with the person.
Well, I certainly think the lessons of not correcting, not arguing, or not sort of trying to use the reasoning and logical,
right.
Responses that we would normally use in remembering that this person has a brain disease, which will require us to respond differently. I think with FTD, there is a lack of empathy sometimes with the other person. So with any of the disease, whether it's Lewy body or vascular dementia, it's one of the reasons a diagnosis is important, because there can be, you need to understand some of the specifics of the person you're caring for.
Depending on the particular form of FTD, I think habilitation will work.
I do too.
There are some aspects of FTD where it may not work as well, and that is where the person may have sexual drives that are very difficult to change.
Yeah. So I think there's so many great questions here, and I'm noticing the time. So Paul, I wanted to just maybe speak to a few that might be MGH specific. Someone asked, how can caregivers get more in-depth coaching or training on this technique? And Paul, I will say that you know this, that you and I we have created different curricula throughout the years, and kind of what we landed on the last 5 years of our work together was a 3-part series, which we're now offering at Mass General, and we're offering it virtually, so anybody can come. Barbara Moskowitz teaches that course, and we spend, we're talking about all of these techniques, but we spend 2 hours or an hour and a half, I would say, just on communication. And then we spend 2 hours just on understanding challenging behaviors and doing that sleuthing, right? Doing the tracing to what may have been the cause of that, and then how do you, create a response to that that will work over time. And then the last class is an hour and a half just on safety concerns. And that really is about when we know we need to make changes, like having additional help come in, taking the keys away, maybe someone has been wandering, they need to, they're having this urge to go out and walk. How do you manage all of these things? Or they don't recognize you overnight, the confusion at night, I want to go home, those kinds of questions. So we spend that whole last class just dealing with those really challenging safety issues, using the foundation of communication skills and understanding challenging behaviors, and then that helps us understand how and when to make changes for safety. So, so we want you to know that we offer those classes every month, and if we get enough requests for that class, well, we can maybe add a class on. We would love for people to have that. If you are receiving care, either in MGH memory disorder unit, including the FTD unit, or geriatric psychiatry, or in the Bullfinch Medical Group, we are able to offer individualized coaching from our social work team. We are limited because we only have a few of our social work staff, but for patients and caregivers who are seen in those clinics at MGH, we can provide individualized coaching. And then the Alzheimer's Association has their 24-hour helpline and can be found at alz.org online, and they offer all of this kinds of coaching, and they have a 24-hour helpline. So this is really it's really exciting for me to get to hear Paul talk about the things that we are teaching all the time, and just the breadth and the scope of how helpful this is, from the, how do you find a diagnosis, to how do you help someone who needs help toileting or bathing or dressing and they're resistant, right? And everything one can imagine in between.
I mean, I really think the basic message here is found in a quote from Eric Fromm, who said, once we're able to value being rather than having, we get to experience the essence of the person we're working with. And
Can you repeat that, Paul?
Once we are able to value being rather than having, it's then that we can benefit from the relationship we have with the person. And that's what I hope caregivers would see. It's not focusing on what the person has or has lost, but it's focusing on what is still there. And what is still there is still the ability to feel emotions, to benefit from emotions, to want to have a loving relationship. That is all still there. And it is up to the caregiver and the family to say, let's focus on being that rather than what has been lost.
Yeah. And so I would say on that note, there was another question, or a comment that someone said, you started out with the toll that caregiving can take on caregivers, especially women. And it really hit this particular person to the core. She had been having feelings that there was some post-traumatic stress from some of the experiences that she's had. So I would just encourage everyone, we encourage people to be educated, and we offer these classes and these monthly conversations with caregivers on a variety of topics. Also, if it's either through MGH or through the Alzheimer's Association, to have individualized counseling and education about your specific situation. And also, Paul, what you mentioned is getting help at home. And we can't sort of let this evening go by without recognizing and acknowledging that this is a really incredible time, that it's really hard to find help right now because of COVID-19. So that day programs that we normally recommend for many, many, many people are not opened. And people are having to make decisions about, bringing someone in the home to help, be that a family member or hiring a caregiver. and trying to figure out testing and safety around COVID, but in getting that help. And I've sort of been, in my work with families lately, it's really been a challenge to decide, is it worth taking the risk of having someone come in to help? Because I see caregivers are really killing themselves. They're really exhausted and, anxious and tired, as we all are. And we need to help each other and to get help in any way we can. So the last thing that I'll mention that I think is so important about all the work that we're doing here and what Paul's talking about is staying connected. Right, Paul? Being able to talk to others. So support groups is another thing that we offer. And again, talking to either an individual counselor or a care manager that's available in the community, et cetera. Do you have any thoughts about that, Paul, the importance of community and safety?
I do. It's very important to maintain those kinds of connections, or to initiate them if they're not there, to keep socially active as much as possible, not only for the caregiver, but also for the person with the disease. I can't stress enough how the social experience can be lost in these times, but how important it is. Music is the magic elixir.
Thank you. I was going to say that earlier. The sensory things, music.
Yeah, and find the music that the person enjoyed when they were young, and put that on your phone, and play that through earphones for the person, or on your stereo or whatever. But it's the music that they appreciated when they were young that has the most value that we've seen, and that has been subjected to research. And we see marked changes in cognition and in sociability just by being exposed to music that has been loved by the person with the disease. And social contacts as much as possible, even now.
And that virtually, like
virtually,
FaceTime,
on the phone. It's extremely important. Doing creative things, artwork. Let me give you a very quick example of.
This will be our last thing. We're wrapping up, Paul. So.
Okay. This can't be quick. Then I won't give you that one. But I would say in that keeping the person socially engaged and in a productive way that brings about positive emotions, particularly as we get into the winter season, is extremely important.
And I'll say programs have all gone virtual. So memory cafes for individuals with memory impairment and their care partners and caregivers. Those are happening online everywhere. You can join a memory cafe anywhere in the world right now. So if you, again, the Alzheimer's Association is a great resource for those of you who are not patients at MGH, Neurology, Geriatric Psychiatry in Bullfinch. But always feel free to email us. Email Nori, and we will guide you in the right direction if you have questions. And if there is a big interest in taking our habilitation class, let us know, and we'll figure it out. We are all about making the caregiving journey and the life with Alzheimer's disease and related disorders the best quality as possible with the disease. So we know there's a lot of quality of life to be lived day to day. It's a long, slow process. So don't do it alone. We're here for you. And Paul, we might have to have you back because there's so much to talk about. We may continue this conversation. For anyone who I didn't get to your questions, please, please, please email us so that we can get a response to you. All right? Are we done? How is that? Any other things to team members? Did I miss anything? Oh, I was going to say our next conversation with caregivers. Thank you, Nori. I could read your mind. Is, I've forgotten her name. Sarah Martinelli.
Sarah Byrne Martinelli. Yep.
Okay. Is a amazing chaplain here in our palliative care department. And she's going to be talking to us about loss and and grief and things that I think, you know, ambiguous grief that I think we're all, anyone who's come into contact with Alzheimer's disease and dementia understands that we need to talk about grief and loss and how to manage that together. And so she's amazing, and we hope that you will join us for that next month. All right. Thank you, everyone, so much. You can unmute yourselves. We can all say goodbye to each other if you want.
Bye.
Thank you, Paul.
Thank you,
Thank you so
everybody.
much.
Thanks so much, Paul. That was
Thank you.
amazing.
Thank you, Paul.
When is the
Thank
next
you,
one?
everyone.
Thank you. Next
Thanks.
month,
September 15th,
September 15th.
third Tuesday of the month.
December? September?
September. I'll send out an email. It's always the third Tuesday of the month.
Thank you.
Put it in your book.
I will.
Sure.
I will.
Thank you, everyone.
Thank you.
Thanks,
Hi, Ellen.
everybody.
I see Ellen waving at you. She just hung
Hey,
up.
Ellen. Hey, Jen.
Hi, Jen.
Bye.
Bye, everyone. Thank you.
Bye, everyone.
Take good care.
Oh, Ellen didn't hang up. There you are. I'm waving at you. I love your background, Ellen.
Bye, everybody.
Bye.